Hello and welcome. Today we'll be discussing a less commonly known but significant complication of radiation therapy: radiation-induced optic neuropathy, or RON. This condition affects the optic nerve, the crucial pathway connecting your eye to your brain, and can lead to serious vision impairment. We'll explore the causes, symptoms, diagnosis, and management of this challenging disease. Radiation-induced optic neuropathy, as the name suggests, primarily arises as a consequence of radiation therapy targeted at or near the head and neck region. Common scenarios include radiation treatment for tumors of the brain, sinuses, or even cancers near the eye socket. The optic nerve, being a delicate structure, is susceptible to damage from the ionizing effects of radiation. The higher the total radiation dose, and the closer the nerve is to the radiation field, the greater the risk. The exact mechanisms behind RON are complex and not fully understood, but several factors are believed to play a role. Radiation damages the small blood vessels supplying the optic nerve, leading to ischemia, or insufficient blood flow. This deprivation of oxygen and nutrients stresses the nerve cells, the neurons and supporting glial cells, causing them to malfunction and eventually die. Direct damage to the nerve fibers themselves and activation of inflammatory pathways also contribute to the pathogenesis of this condition. The long-term effects of radiation can lead to demyelination, a loss of the protective coating around nerve fibers, further hindering nerve function. RON is a relatively rare complication of radiation therapy. The incidence varies depending on the location and type of tumor being treated, the radiation dose delivered, the fractionation schedule, and the individual patient's susceptibility. Higher doses of radiation, particularly those exceeding 50 Gray delivered in conventional fractionation, significantly increase the risk. Patients with pre-existing conditions like diabetes or hypertension may also be more vulnerable. While precise numbers are difficult to obtain, understanding these risk factors helps clinicians to minimize the potential for this debilitating side effect. The symptoms of RIO can vary, but they typically involve a gradual, painless decline in vision. This may manifest as blurred vision, decreased visual acuity, difficulty distinguishing colors, or a constricted visual field, a narrowing of what you can see peripherally. In some cases, patients may experience a complete loss of vision in one or both eyes. Symptoms can appear months or even years after radiation therapy, making timely diagnosis challenging. Any new or worsening visual disturbances following radiation treatment should be promptly reported to a physician. Diagnosing RON involves a comprehensive ophthalmological examination, including a thorough assessment of visual acuity, color vision, and visual fields. A dilated eye exam allows to examine the optic nerve directly for signs of swelling, pallor, or other abnormalities. Imaging studies such as magnetic resonance imaging or MRI of the brain and orbits can help rule out other potential causes of vision loss, such as tumor recurrence or compression of the optic nerve. Visual evoked potentials, or VEEP, which measure the electrical activity of the brain in response to visual stimulation, can also be useful in confirming optic nerve dysfunction. While there aren't distinct types of RON, it can be categorized based on its severity, ranging from mild visual field defects to complete blindness. The classification usually considers the degree of visual acuity loss and the extent of visual field impairment. It's also important to differentiate RON from other radiation-induced eye complications, such as cataracts or dry eye, which require different management strategies. Unfortunately, there is no definitive cure for radiation-induced optic neuropathy. Treatment primarily focuses on managing symptoms and preventing further vision loss. Corticosteroids, either oral or intravenous, may be used to reduce inflammation and swelling around the optic nerve, but their effectiveness is variable. Hyperbaric oxygen therapy, which involves breathing pure oxygen in a pressurized chamber, has shown some promise in improving blood flow to the damaged nerve. Vascular endothelial growth factor inhibitors, or anti-EGF injections, may be considered if vascular damage is thought to be a major contributor. Low vision aids and rehabilitative therapies can help patients adapt to vision loss and maintain their quality of life. The most effective strategy against RON is prevention. This involves careful radiation planning to minimize the dose delivered to the optic nerves during radiation therapy. Techniques like intensity-modulated radiation therapy, or IMRT, and proton therapy, which allow for more precise targeting of radiation, can help spare surrounding healthy tissues, including the optic nerve. When the optic nerve cannot be avoided, lowering the total dose of radiation, or using fractionation, dividing the total dose into smaller doses given over a longer period, may reduce the risk. Regular eye exams after radiation therapy are also essential for early detection and management of any developing problems. The prognosis for RON varies, with some patients experiencing stabilization or even partial improvement in vision with treatment, while others continue to experience progressive vision loss. Early diagnosis and prompt intervention are crucial for maximizing the chances of a favorable outcome. Recent research is exploring novel neuroprotective agents and targeted therapies that may offer hope for future treatments. Gene therapy and stem cell therapy are also being investigated as potential strategies for repairing damaged optic nerves. As our understanding of RION improves, we can expect to see further advances in its prevention and management.